The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to today's webinar presented by HSG Virtual Health, Optimized Patient Access, Capture, and Retention. My name is Travis Ansel, Managing Partner at HSG. I'm joined for this afternoon's presentation by Dr. Terry McWilliams, Director and Chief Clinical Consultant for HSG. Before we begin, a few housekeeping items. We welcome any questions you have. You can submit those via the webinar questions tab on your control panel, and we will answer as many as possible at the end of the webinar. We will not identify your name or organizational affiliation when submitting those questions. If you have a question that we cannot get to during today's program, we'll be sure to follow up with you by email afterwards. A video recording and slide deck of today's webinar will be sent directly to you via email and will be available for on-demand viewing at www.hsgadvisors.com by this time tomorrow. All right, well, let's jump into today's topic, virtual health. Very timely because, Terry, I think we're getting a ton of questions from organizations across the country about what's going on with virtual health, where reimbursement for virtual health is going, and where in the strategic plan, I guess, virtual health should live. And so today, the things that we organized this presentation around, one, we wanted to talk about how virtual health should be evolving to be a pillar of your network's patient capture and retention strategy, because we believe it's critically important that organizations not lose inertia around virtual health. Two, we want to talk about the evolving nature of the telehealth regulatory and reimbursement environment, which of course is driving a lot of change and a lot of questions. And then three, we want to talk about some of the barriers we see to long-term virtual health adoption and how we might advise health systems to anticipate and mitigate those. If this is a topic that really interests you, you can see on the screen, we've done two previous webinars this summer during the COVID era, since everyone became interested in virtual health in April and in June. Those are available on our website as well. So let's start by getting some common definitions and what virtual health means to us, and then let's talk about what we see going on right now. So when we talk about virtual health, again, just making sure we're all on the same page. Virtual health, form of remote telehealth delivery in which patient-provider interactions occur through telecommunications. That can be real-time, or that can be asynchronous, so through your EMR, EHR portal, through email, text, whatever. When we talk about it, our focus is on the office-based care environment, so that while there are applications outside of office-based HSG, we focus on the ambulatory side for the most part. So that's what we'll be talking about today. When we think about virtual health, reasons why we would see its long-term adoption being beneficial: patients generally like it. It's convenient, gives you quicker access, generally, not always, lower cost. Providers who've adapted to it find it convenient, like the ability to the flexibility in scheduling, like the ability to manage their day when they have especially asynchronous communication that can work into their schedule, removes the transportation barrier that they see with a lot of patients, and provides better access to specialty referrals and consultants that maybe we would normally have a hard time getting patients to. And we see health system administration teams like it: decreased cost of care, increased operational efficiency, we get the schedules full, we get more patients through. So all of those benefits exist. But what we've seen, and the reason we've not seen virtual health really adopted up until April, and I'm speaking generally, of course, because it obviously varies market to market. We've never really seen sustainable reimbursement for it in the fee-for-service environment. So while we said on the last page, patients that use it generally find benefit, we've always, of course, seen historic patient preference to see providers face-to-face. Same thing with providers preferring to see patients face-to-face. And then we've always had the barrier of HIPAA compliance, how we protect patient privacy, a lot of which is, we've obviously seen temporarily barriers around that go away during the COVID era. but certainly don't have any long-term protections for those in place. And then the proliferation of technology that allows virtual health, especially internet bandwidth, it being the big challenge we see, especially in our more rural clients environment, has historically been a barrier. So what changed in April? Well, we saw the sudden explosion of COVID as the public health emergency was declared. We saw elective face-to-face encounters go away. We saw providers wanting to get patients virtual to conserve PPE. We saw regulatory restrictions relax, especially around privacy, allowing for easier virtual health interactions. And we finally saw reimbursement kind of catch up and started to see fee-for-service reimbursement. We saw CMS and other insurer waive regulatory issues and change reimbursement that allowed us to get reimbursed for virtual health. And then perhaps because just out of necessity, we saw providers and patients left with no real other options, be forced to adopt virtual health. And so we're still in that period. But it was interesting because Terry, I guess as we worked through April and May and worked with health systems to try to figure out, okay, what are the implications of virtual health? I think we were all convinced this is here to stay. We have to be able to maintain our current telehealth virtual visit volume. We have to keep building our resources because this is really the next frontier that we're going to be fighting on for patient acquisition. And we did a study, survey to numerous health systems and healthcare executives between April and May, and we heard 94% agreed that delivery of virtual visits will be a key part of our strategy even after COVID-19. And with a specific comment that we like, that telemedicine has changed how and where our primary care physicians will work. So that all made sense to us. But then as we looked and started thinking about the current state, what we're now seeing is that we saw a lot of organizations start utilizing virtual health modalities really because they had to. That was the way that we sustained our ability to deliver any patient care. But whereas a lot of us thought we were going to see an augmentation of care, where we're going to start seeing maybe a mixture of both in-person and virtual visits become the norm. We really haven't seen that momentum sustain itself as we've gotten into June, July, and August. And as states have opened back up and as electives have resumed and as in-person visits have resumed, we've seen a lot of these changes recede. So commercial payers that had promoted favorable reimbursement for virtual health over the last few months have seen that go away or be lessened. A good example of that is reimbursement for telephone encounters. Providers, I think a lot of the providers we talked to, even those that had gotten very busy very quickly on virtual health, virtual visits, we heard through the summer, I just can't wait for things to get back to normal. I can't wait for the office to get back to normal. I think there's a lot of familiarity, probably not just in the current work environment, but just in what is 2020, where any resumption back to normal feels good. So we've seen provider acceptance started to wane on tolerating virtual visits as part of their daily business. And then patient acceptance really we've seen that start to gravitate back towards those traditional cohorts of the under 40 crowd being very tolerant to it, the over 40 crowd, not as much, that Medicare age really not being tolerant of it. So we've started to see things fall back to normal, which to us is a lot of the reason we wanted to talk about this today, because we still see virtual health as being very important. This chart we have here on page 11 shows basically the rebound. This is a primary care office that we pulled data on, showing basically the blue line phone, the orange virtual, and the gray line being in-person visits. So basically showing the drop off in March and the corresponding rise in virtual and telehealth communications, but seeing that by the end of May and early June, when this state reopened, the virtual and phone going away and not going and basically going back to normal. When we look at urgent care and ED on the next slide, we've seen a corresponding trend that has really interesting here. One, obviously, we saw phone and virtual not become as prevalent in the urgent care environment because it is urgent care, of course, by its nature. But what's been interesting is not only have we kind of gone back to largely in person as a percentage of visits, but the volumes have not made it back up to where we were before COVID. So while primary care has largely rebounded, urgent care has not. So really interesting. But the overall takeaway between the last two slides is that, well, we're largely seeing business go back to normal. So, where do we go from here? So, from our perspective, what's going to happen post-COVID to us, still very uncertain. We're seeing a lot of advocacy for continuing the inertia that's been created over the last 4 months around telehealth regulatory and reimbursement changes. From what we've seen from CMS, we see maybe a little bit of promise, but nothing that would be fully in support of maintaining the current status quo on virtual health. The 2021 proposed Medicare physician fee schedule final rule, which came out earlier in August and then was published on August 17th. We're seeing some waivers, with the continuation of some waivers of reimbursement through the end of the calendar year, whenever the public health emergency concludes. Very doubtful that's this year, but at least through 21. So that would include things like telephone visits, ED visits, sniff, psych, and neuropsych testing. And it also would permanently add several visit types to permitted interactions, which is what we've seen a lot of advocacy for. So home visits, group psychotherapy, neurobehavioral status exams, and care planning for patients with cognitive impairment. So all of that relatively positive, but for everything else that's not in that list, everything's still kind of in an uncertain landscape from CMS. And because CMS is uncertain, we're also seeing the commercial insurance response be uncertain. So a lot of uncertainty going forward. So what does that mean for the future state of virtual health? So as we said, a lot of it's unpredictable, but from HSG's perspective, and Terry's going to talk about some of the opportunities and threats that virtual health presents to health systems going forward. From our perspective, we see virtual health we still see it as part of the future strategy for patient access and patient acquisition going forward. And so we recommend that each health system should be working to augment current services through virtual visits and maximize reimbursement for them, at least through the end of the public health emergency. We should assume that the post-COVID environment is going to be similar to the pre-COVID environment because that's what we're seeing already. So while we think virtual health is important, we should note that that's not where the market's going at the moment. We really think if organizations do choose to continue pursuing a virtual health strategy, it should be a true telehealth strategy and not just this is the way we're getting patients in while we can't see each other face to face. From our perspective, that means doing a true evaluation of our capability to deliver telehealth, and really putting that not just in the context of can we get our current patients seen virtually, but can we actually go out and change our patient market share through the execution of our telehealth strategy. And Terry's going to talk a little bit about how we see that being done, as well as threats to organizations who aren't pursuing that type of strategy. Terry?
Thanks, Travis. And as we look at some of what we perceive to be, threats and opportunities for health system in the world of telehealth and virtual visits, it would like to just reemphasize a couple of things that Travis just said. A lot of the interactions we have with, and I'm not talking about the the very large wave leading organizations that as a rule have a telehealth strategy and are pursuing it. But I'm talking about more the majority of organizations that looked at virtual visits and telehealth as that substitution. During this time when we can't do anything else, this is what we need to do. And it was more of a survival instinct as opposed to a strategic imperative. And a lot of these same organizations said over the next 5 years we need to, but didn't really create great action plans. And so I think personally, and coming through in what we have on this slide, is I do think that telehealth can be part of our armamentarium on a regular basis, and we'll talk about that. But I think we really need to look at what are people doing well that's really a threat to us and a threat in our patient capture and retention strategy, and what opportunities might we have to be able to utilize any momentum that we gained at the height of the pandemic, and for some markets who are still quite impacted by the pandemic. How can we use that and some of the lessons learned to really move forward in a very strategic fashion, as opposed to a reactive fashion or a substitutional fashion, or only because we have to kind of fashion? So as we think of some of the threats that are out there, the first one to mention is the threat we had coming into the pandemic, and that is there are a number of national companies that were not only gaining prior to the pandemic, but really consolidated their hold on the market, and increased shareholder outcomes, meaning they became even more profitable during the pandemic, and expanded their services available online. For these organizations, the convenience that they offer is hard to match. They are actually a favored option for younger generations of patients. Keep in mind that many of these same younger generations are those that feel that there's not really a need for primary care. I only need access to medical care or health care when I need it, as opposed to all along. And so this represents a great opportunity for them. These are the same individuals that tend to use urgent care as opposed to primary care. And where urgent care is not available readily or conveniently, again, utilizing emergency departments as well. The other aspect to think about in this area of threat is these companies are now partnering with human resources department and becoming part and parcel of employee benefits packages. And we're not only talking about outside employers, but we're talking about many of our own health systems as well. So they're coming into a package deal, so to speak, and becoming even more readily available to our patients. One example of a company like this is Teladoc. There are others, American Well, which is now going by Amwell, MD Live, Doctor on Demand, many others. But if we focus on Teladoc just for a second, which is perhaps the most well-known, and we look at the scope of services they offer, there's the traditional minor acute care and non-emergency kind of acute issues, but they've also kind of branched down into other non-emergency medical issues and minor chronic care. They're offering pediatric services now, previously primarily adult and dipping into minor acute care in adolescents and kids, but expanding into teledermatology, telemental health, and that whole realm of areas that each of us could be doing if we set our minds to it. But they have the services in place and do it very well. Keep in mind that these organizations are not hampered at all by getting prescriptions to patients. They have electronic prescribing to local pharmacies just as you do, and they provide that service quite well and quite conveniently. Most of these organizations function with an upfront flat fee payment for the service, and the amount varies by service. So on the website for Teladoc, they list a $49 upfront payment for everyday services, the minor acute care, non-emergency medical care, and that type of care interaction. $75 for a basic dermatology interaction, and then upwards of $90 for mental health counseling, which again is mostly a time-sensitive issue. This is not their entire fee schedule for sure, but just presenting on the front end, the way they do business is they have a flat fee for service. They collect up front, and to date, even pre-COVID, patients are willing to pay for that convenience and do so quite readily. The other threat, and I kind of alluded to this when I talked about large systems that have a very well-developed virtual care strategy and presence, is that these are large health systems coming to an area near you. They may already exist in an adjacent market, or they're just branching out based on their reputation to capture markets that are quite distant from their actual location. So one example of this, and it was an easy one, I think, in my mind, is to talk about the Cleveland Clinic. Now, just about everyone across the country has heard of the Cleveland Clinic. Many across the country think that the Cleveland Clinic provides great services, and wouldn't it be great to avail ourselves of services in the Cleveland Clinic, even though I live, 1,000 miles away? Well, Cleveland Clinic advertises express care online for common medical complaints, dermatology, urology, and women's health. That kind of service line that was listed for Teledoc. They also are offering online second opinions. And the quote that's on the screen there is actually a quote from their website. And imagine you can access the expertise of our top physician specialists from anywhere in the world. Chat with our experts via telephone or to thoroughly review your diagnosis and educate you on treatment options. I mean, wow, right? And to top that off, they partnered with American Well almost a year ago in a joint venture that they call the Clinic. And it offers virtual care from Cleveland Clinic's highly specialized experts through American Well's digital health platform to reach out almost in an unrestricted offering. So you don't have to be in the general Cleveland market or even in the upper Midwest market. This reaches out everywhere, including the population that your health system serves. So two large threats from the outside: the national digital health platforms, but also many large health systems are expanding their robust online services. So what do we do about that? Well, we could just say, well, those are big areas and we can't compete. But the other is to really look and say, can we compete? Does this really represent an opportunity? Did the pandemic have a silver lining as far as virtual care and getting into the virtual care business? Yes, we did it because we had to then, but maybe we can utilize some of the things we learned and some of the acceptance that even if it's just transiently there, some of the acceptance on both the provider and patient aspect to really incorporate virtual visits as a patient-centric care delivery offering that might differentiate us in our market and might allow us to expand our market. When I say patient-centric care, I should just qualify what we mean by that. Everybody talks about patient-centeredness and everything else, but in patient-centric care, the focus is on what is best for the patient. Now, most of us say, especially most of us clinicians, will say, we've always had the patient's best interests at heart. Well, we have, as long as it was under our circumstances. So, for instance, many of our office environments are very provider-centric, and I would say even physician-centric, but very provider-centric, from our hours of operation to how you access us, to all the rules of accessing us, to yes, you have to come, and yes, you have to wait, and yes, you have to spend half your day for a 10-minute appointment. If we're really thinking in a patient-centric manner, If I don't have to drive there, if I don't have to sit in the waiting room, or even if you get me in an exam room for, very quickly, in the exam room waiting for somebody to come and provide care, and then I have to, and then I have to, and then I have to, gee, if I don't have to miss a half day of work or find childcare or find transportation, wouldn't that be great? Now, most of us would agree that not everything can be managed via virtual visits, but there are many things that we can creatively manage through virtual care. One aspect that's actually, I think, even mainstream now is looking at having a percentage of our interactions for chronic conditions be through a virtual care manner. So, rather than dragging the patient into the office every quarter or every 6 months for stable chronic conditions, especially stable chronic conditions that have a lot of numeric management. So, for instance, hypertension. What's your blood pressure been doing? Diabetes. Let's talk about what your labs show and how you're feeling, and that can be done virtually. Hypothyroidism, except for the thyroid exam, which for most cases of chronic hypothyroidism isn't really an issue. Most of that can be done entirely virtually. But let's not go quite there, and let's just say that instead of having every visit being in person, maybe do 1 and 2, 1 and 3 in person, or even 1 and 4 over the course of a year, and the others might be able to be managed virtually. Another aspect involves a lot of our follow-up interactions that don't really require a whole lot of laying of hands. So some of our early post-procedure follow-ups or medication changes or initiation of antidepressants lend themselves to conversations and with augmentation by video capabilities. And so we can perhaps, especially when the patients are at their most vulnerable, allow them to be in a comfortable environment, not dragging them into the office with all the impediments that creates. And maybe some of these can be conducted virtually. And then finally, in looking at this, the whole expansion of reach concept, and the probably more notable areas are the ones that we already saw that others are doing. Urgent care, meaning minor acute care. Telemental health has a lot of backing, as well as teledermatology. So perhaps we can expand our reach as a differentiator, as a differentiator in our market, in offering these, and extend beyond our brick and mortars to capture more people, to capture them more conveniently from their perspective, and provide greater care to a greater population. Hence, greater patient capture and hopefully greater patient retention. To do this, though, we'd have to convert our mindset from that substitutive kind of process of interim necessity to a sustainable standard practice. We also have to ensure that all the regulatory and reimbursement requirements are readily met, both that were waived and currently in place in the public health emergency for COVID, but also in that post-COVID reality, most of which remains uncertain, and we readily acknowledge that. So, how can we maximize, or how can we make use of these opportunities? One element that's been found to be quite successful in the world of virtual visits is to treat them just as you would as if they were in-person encounters. So, think of the things that we all do as we get ready for in-person office encounters. Well, we review the record. We make sure that the record and all the outstanding information is present. We make sure the patient is there and roomed, and then we have the face-to-face encounter. Similarly, we should prepare for a virtual encounter in much the same way and be ready for the encounter so that when there is the direct interaction between the patient and the provider, the patient is well prepared for the interaction, the provider is confident that everything is in place, and the two have a great encounter. Now, clearly, we tried to hit it in the previous slide. Clearly, we should choose these interactions wisely to best utilize our time and effort, and to provide care safely and effectively, not just efficiently. We already talked about being prepared, and it's really funny. No, it's not funny, but it is kind of funny. Um, Even in-person visits, our countenance comes through, right? So if we're very harried, it's been a busy day, we're trying to get through the day, that comes through in all of our interactions, and not only verbally, but non-verbally. Well, that same thing comes through verbally in the virtual encounters, and if it's virtual with video, then all the nonverbal comes through as well. One of the things I found really interesting, and this is the funny thing I was alluding to earlier, is there are a number of individuals who advocate smiling even if no one can see you. So even if it's not a video visit, smile, because everything that comes through verbally reflects differently if you're smiling than when you're scowling or if you're hurried. Um, and so smile as if you're in front of somebody and you want to be as pleasant as you can, because that smile is actually portrayed in your voice inflections and how you come across. Now, those of us who do webinars, well, let me rephrase that. When I do webinars, I shouldn't speak for everyone else. I almost have to psych myself up like I'm talking to a room full of people, because if I think about these as I'm just sitting in a place all by myself looking at a computer screen, I'm probably going to come across even more boring and monotonous than I would if I'm really trying to be excited, like I'm talking to a crowd of people that are sitting in front of me and we're making eye contact. So I understand this, but it just is an interesting kind of a tenet to think smile, even if they can't see you, because they'll hear it. Engage the patient directly and be present and attentive in the interaction. It's not the time to multitask and do a bunch of things. Just as you would try not to do that when you're in a face-to-face encounter, engage the patient directly, be present and attentive, and focused on the time at hand. A difference, and only a slight difference, we tend to give a whole bunch of educational information in bulk during in-person encounters, but during virtual visits, it's especially preferable to break them into digestible pieces, and even splitting into successive briefer interactions. Like, I'll tell you what, let's focus on this right now. We'll do another call tomorrow or another video interaction or whatever tomorrow, and we'll talk about the second step and answer any questions you had about the first, et cetera, et cetera. They found that in virtual encounters, it's even more important than in-person encounters to make sure the information is digestible and in smaller amounts. Again, looking at agreeable follow-up plans or instructions, making sure we understand, but even more importantly, because we don't have a great, nonverbal interaction about understanding, the repeat back verification becomes even more important. Could you tell me what I just said? And if it is video, you can be looking at the patient to make sure that there seems to be understanding. And I say this because often in person we get that, we just look for the nod and they may not understand. And repeat back is advocated there, but even more so advocated in the virtual visits. So, even though we don't know what's going to come out of the post-COVID time as far as virtual health regulatory changes or reimbursement changes, and in spite of what the administration is currently saying that we want to expand and we have all these plans, there really isn't anything concrete right now except what Travis went over in the proposed Medicare 2021 physician fee schedule. So if we're not going to have all the waivers we have during COVID afterwards, then during this time is an opportunity, while we have that ability still present, to look at things that might not be there after the public health emergency ceases. So technological issues, scheduling issues, figuring out reimbursement issues, looking at how we might want to do this on a long-term basis for all those areas. And how, if we do this, how would we market it to our patient population to make it a favorable option for them? What have we learned about provider and patient adoption barriers, especially, and back to that curve that Travis showed, with the telehealth going down and the in-person visits going up, what is it that we've learned about the barriers to continuing telehealth? Did we just say, oh, we're done and let's go back to normal? Or were there reasons, and what can we learn from that so that we can improve upon that in the future? And lastly, the whole thing about market presence. What are our competitors doing? What are our opportunities in that area? And can we take advantage of those? I hate to get back to finance, but Travis would kill me if I didn't. Well, not kill me. That's a little bit drastic. But be upset if I didn't. As we look at risk contracting and progressive risk contracting, we look at total cost of care. And especially if we look at full risk contracting as manifest by a capitated reimbursement environment, being able to address things in the most cost efficient manner becomes very important, does it not? So, in the office-based care side of the equation, the most expensive interaction is the face-to-face encounter in the office. The least expensive interaction is a virtual visit. Well, actually, there may be other least, but a less expensive option is a virtual visit. It will require less staff time. It will require less provider time because we're going to focus on specific issues. And if much of the office interaction was going to be social in nature, which is not uncommon with our geriatric patients, the virtual care can accomplish the same thing, especially a video virtual visit. We have that social interaction. We can spend a little bit of time on the niceties of life, and we can address it and bend the cost curve, which is going to be very important with progressive risk contracting. This is also an element, if we talked about direct to employer contracting, again, we're looking at, HR benefits packages that have telehealth as one of the elements. And so they're out there, it's available. And if we can offer that in a direct to employer contracting arrangement, isn't that fantastic and beneficial to us? So as we think of opportunities, and this is a little bit different than a true opportunity slide, but just to reemphasize what is kind of known that will be there in the post-COVID timeframe. The things that were put out in the 19 and 20 and coming in the 21 Medicare physician fee schedule will continue to be recognized and reimbursed by Medicare fee-for-service programs. And again, there are many restrictions and limitations that we reviewed in our first webinar that was listed in the front of the slide deck. But virtual check-ins, e-visits, the imaging part of things, store and forward communication where you can send a picture and interpret it, interprofessional internet consultation and these others are going to be there. Now, they're not perfect, but if you think about when they arose, we were kind of excited that we were going to receive RVU credit and payment for previously unreimbursed, what we would term indirect patient-related interactions, right? So, it was a step in that, continuum of moving toward value-based care with risk contracting, that we were finally going to get time, recognized for the time spent and the effort expended to interact with patients in an other than in-person face-to-face interaction. Now, clearly, the rates in RVU credit are less than office visit because what they're designed to do is of lesser complexity and has less associated overhead than an in-person face-to-face interaction. That has caused, and we've heard this a number of times, providers say, well, if that's the case, why wouldn't I just bring the patient into the office? I get paid more, and we'll show you the comparison in just a second. Not I get paid more. Well, maybe I do because I get greater RVU credit. So I get more RVU credit. The office gets reimbursed at a greater rate. Why not just keep doing what we're doing? That's what fee-for-service is all about, isn't it? Well, again, an opportunity here is trying to bridge the gap between pure fee-for-service and volume-based care and where healthcare is going because, there are great forces pushing us that way. into greater risk contracting, into value-based care, and perhaps ultimately into capitated care. The answer then is not just bridging, but because it's patient-centric care, it's much more convenient for the patient to deal that way, and we get some credit for it, and we can do more in less time. If you really think about it, and we really do it well, and this is done efficiently, we can do more in less time. So, perhaps these can offset themselves a little bit more. We're going to put in this table that we had in our previous webinar, but just to show you the difference between some of the office visit reimbursement and RVU credit for time spent and the CMS approved virtual care encounters. So clearly, there is a difference, right? And no one should try to sugarcoat that. But the opportunity in this is we potentially can do a patient-centric form of care delivery that will help bridging toward our future risk contracting area and still get reimbursement and RVU credit for it. That is an opportunity, especially if we did not do anything to incorporate this from 2019 on, and we continue to provide those services without any RVU credit and without any reimbursement. So if we're doing it, we might as well get reimbursed for it. We might as well meet the criteria. We might as well figure out how to do it. And again, we can increase our RVU credit, increase our reimbursement for effort that's already expended. What could be better than that? And if we're not doing it, then we should. So I'll get off that soapbox for a second. Look at again, still looking at our opportunities during the COVID public health emergency as we're under a favorable virtual health environment. Think about our business operations. Teladoc, American Well, they don't care about third-party reimbursement. They don't care if the health insurers cover it. They charge up front. They take payment before the care is rendered. And it makes them a financially sustainable organization. If we enter this, and keep in mind, right now, during COVID-19 public health emergency, we can waive the Medicare copays and deductibles. We don't think that'll happen post-COVID, but still unclear. But if we are going to confine ourselves to future virtual care and have it and pursue third-party insurer reimbursement, think about how copays and deductibles will be collected. Do we do a credit card charge at the interaction? Do we incur delayed billing? And we all know that collecting copays and deductibles by delayed billing as opposed to collecting at the point of service is fraught with issues. Do we ignore health insurer payment and just charge a flat fee like our competitors would on a national scale? These are all things that come into the strategic thing, how it fits in with your organization's philosophy, and how we want to approach this over the long term. Do we want to differentiate ourselves by saying, well, Teladoc or American Well, they'll charge you right up front. We'll try to work with pick your health insurer and see if we can't, work with them and work with you to minimize your cost in this, but just focus on collecting your copay or deductible up front. So these are all aspects to kind of work on. The other aspect to work on is the whole documentation, billing, and coding aspect that can be quite complex. Making sure that we're compliant with all the regulatory and other requirements. How can we do it with minimal disruption to the flow and with minimal burden placed on our providers and our support staff? One way in the documentation is to try to develop our EMR templates to get everything that's necessary in the most convenient fashion, and to have it be almost a visual reminder of all the things we need to do to make sure we don't forget anything. Now, that doesn't mean the provider has to do all that, Our support staff can help collect a lot of that as well and document it, because remember, in the physician fee schedules over the last couple of years, and reemphasized in the proposed 2021 PFS, is that our support staff can do a lot of the documentation, and we just have to verify it. So again, allow the staff to help us with that. Coding education programs and point of care aids are going to be important in this to know that we're doing it correctly. And again, tons of communication in both directions with office staff, providers, and especially revenue cycle staff to make sure that we're doing things correctly, we'll survive audits, and we'll be all fine. Keep in mind that during COVID-19, they're not going to audit us. So this is a great time for lessons learned, another opportunity. Great time for lessons learned to see what we're doing that wouldn't survive the post-COVID timeframe, and make sure that we can revise our processes now where we're during a time that it won't hurt us as we move to the post-COVID realities. And then marketing, within and outside the practices, showing that what we're doing and why we're doing it, especially why we're doing it for your benefit, the patient's benefit, and how it differentiates us in the market. Continue on that bent, when we look at our contract negotiations with our commercial payers, sometimes we don't think outside the box, and this is an opportunity to think outside the box. Can this be made into a mutually beneficial arrangement that we can have the same benefits that CMS is giving, or increased benefits over what CMS is giving with our commercial payers? Many times there's a complete disconnect between third-party payer contract negotiations and the reality of what we like to do. There's the opportunity now to look as if we do this, what will happen on our provider compensation model? Are there special considerations, as we look at the potential impact? Can we model out financially what it might look like, depending on how we approach virtual health and virtual care delivery? Do we need to modify it to incentivize that behavior, or to capture that behavior, or to avoid a negative impact of virtual care on our compensation plan and individual compensation? What's the budgetary impact of all these changes? And again, the strategic planning impact to have a regional presence, to expand our brick and mortar presence without having to construct actual structures to do this. Can we put kiosks in our urgent care environment to expedite care? Can we, can we dedicate some urgent care staff to not only face-to-face encounters, but also our virtual encounters, to be able to maximally utilize the staff, especially if we're going to have a slow return on our volumes, as noted in that earlier slide? How can we actually use this as we plan for the future, and how can we incorporate this aspect of care delivery as we look to the future? And can this differentiate ourselves? Can it be a mechanism through which we can increase our patient capture, or more, and as importantly, increase the degree of patient retention? Keep in mind our younger adult patients, as we look to the future, are very invested in this type of patient care interaction. It's an opportunity, back to this opportunity things, to make sure we can reach out to that patient population that we serve, and capture more of those and retain more of those over the long term, because they are not as excited about the traditional care delivery models as our providers are, or our older, as our more traditional patient population has been. So with that, shifting gears again, and just wanted to reemphasize some of the resources that are available as you consider some of these options. CMS has a whole telemedicine toolkit with a lot of links to resources that cover the basics, different vendors, different technical assistance, CMS policy. There is a section related to COVID-19, but most of this toolkit applies to the pre and post-COVID public health emergency. There's a broader telehealth.hhs.gov that provides information for both patients and providers. There's different pathways to click on to go. On the provider, their elements are listed here, including legal considerations and links to multiple sources. Both of these have links to multiple sources. And finally, the AMA has a telehealth implementation playbook, which is a very expansive document that kind of takes it from soup to nuts, including having an evaluation process, and has a bunch of forms and other resources for consideration and customization. It's actually a fairly extensive resource, and all of these can help as you decide that you want to take advantage of this and incorporate virtual health in your long-term care delivery. All of these can be resources that can be very beneficial as you map that out. So Travis, I know I've been talking a lot and talking fast, and I apologize, but I think some of the things we've talked about today that we wanted to emphasize, and correct me if I'm wrong, we really think that we can utilize virtual health, virtual visits, virtual care in general as a mechanism to enhance the capture and retention of patient volume now and in the future. I think we said that enough times and emphasized that enough times that really this is something that you can look at. Everybody talks about leakage. This is a different type of leakage, a little bit difficult to measure because again, no matter how we measure leakage, it's going to be hard to figure out how many folks didn't come to us and didn't go anywhere else because they went to Teladoc, for instance. We can augment our current service delivery in a patient-centric manner and engage patients in a manner that is most convenient and most acceptable to them as an individual. We can provide patient care through a mutually convenient, secure mechanism that can differentiate us in the market. It can expand access to all of our practice services, including urgent care, and expand access for patients because some of the barriers and the social determinants of health can be overcome because we're meeting them where they are. We can safely deliver care in a very cost-effective manner, especially if we target how we're going to utilize this and what advantages it might offer. And finally, it can better prepare us as we progress in our risk contracting and the value-based care environment, so we can set ourselves up for even greater success in the future. Travis, did I miss anything with that summary?
I don't think so, Terry. I mean, again, I think it's worth I think we have repeatedly reemphasized this is just the perfect time to not let our momentum slow down, even though the environment is seeming to shift back to pre-COVID activity level. I think, Terry, you've made a very convincing pitch that a lot of these capabilities are one that we need to continue evolving and will be beneficial both from a patient care perspective as well as say health system success perspective. So I think we've got it here.
All right. Well, with that, we'll look for any questions that were submitted. Let's see.
And Terry, while we're looking, I just want to let you know that the entire time you were talking, I was smiling.
Well, it didn't come in through in the words you didn't say.
Well, there you go. It does not look like we have any questions, but if anyone does have any questions, please feel free to submit them to our email addresses, which are on slide 2 of this presentation. And again, this will be available on www.hsgadvisors.com. Both the presentation and this presentation and the slide deck should be available by tomorrow afternoon. Terry, anything else?
One thing that just dawned on me, and I didn't see it there, but we didn't talk a whole lot about making the business case and looking at the ROI. There are many ways to do that, and some of those resources can help you. But if you think about it, with some of the data that you were able to generate during the height of the use of virtual visits, back in March, April timeframe and into May, and maybe even now for some of you, you might be able to get an idea about, how many of these were of various types we're talking about, what the reimbursement might be in the post-COVID timeframe, what advantages there can be to offering virtual care even on an urgent care basis. How can we expand our just about every market has an issue with mental health access, and just about every market says we need more dermatologists. To which we say, boy, but they don't pay. Right, Travis? Medical staff development planning, don't
Exactly.
dermatologists. And I only sort of apologize to my dermatology friends out there. But these are ways that we can look at increasing our scope of services, and some of that can be a little bit difficult to project, but there is a business case that can be made for this.
Okay, well, with that, we'll thank everybody for their time. Thank you, Terry.
Thank you, Travis.
All right, goodbye.